A patient used the word positional the other day at an appointment, and she doesn't know how that is often music to my ears. When we talk about things being positional, yes, it could be the position of the muscle or the tendon or the ligament, but what I'm focused on most, because of prevalence when it comes to musculoskeletal disorders, is position of joints. And this was not on my radar as much before I started learning about mechanical diagnosis and therapy, or MDT. The position of joints is identified in multiple planes, but the primary positions we're talking about are flexion, extension, abduction, adduction, internal or external rotation or right or left rotation, side bending to the left or right, and multiple others. Each joint has its own degrees of freedom and its own positions that it can be in, either moving into a position or sustaining a position. In this particular patient's case, she has had decades of unexplained dizziness that can produce vomiting and fainting, and hasn't had much resolution or definitive diagnoses from other clinicians that she's seen. So she presented to me with intrascapular pain, which is pain between the shoulder blades, radiating pain into the arm, down into the hand with paresthesia in the hand. Now, for me, I'm trying to understand if this long history of dizziness complaints, etc., has to do with this problem in her neck, which has been responding to mechanical movements. The arm pain was 80% reduced with retraction extension, and I think we're on our way to getting all of the pain gone quite quickly. But what I strongly am suspicious of is that all these dizziness, vomiting, fainting symptoms are also due to a mechanical problem in her lower neck. So when she told me recently, I'm getting this dizziness and it's very positional, that makes me really happy because it increases the likelihood that the position of her neck is what contributes to the dizziness. Yes, can the position of her head have to do with the crystals in her ear and the position that they're in? Yes. Can it be due to positions of other things, things that are less common or less understood, like things in the brain or the brainstem or other musculoskeletal structures like tendons and ligaments and muscles? Yes. But I highly suspect for this particular patient that positional means positional in terms of the joints of the spine. So when she's in a certain position on her sofa, she can produce the dizziness. And when she's in a certain position in her bed, she can produce the intrascapular pain. So like I said, I strongly am suspicious of the fact that this is all one problem, especially because she's been to other clinicians, not clinicians who are necessarily physical therapists or who understand how to do repeated movement testing to assess for mechanical problems. And they have not been giving her concrete ideas other than possibly hydration or doing scans and ruling out disorders of the brain and the brainstem. So positional can mean lots of different things. But with the lens of joints, I want you to start thinking about positional, meaning the position of the joint is what's actually the problem. Now, for patients, this is a little bit hard. You need to understand, for example, that the low back goes into flexion, extension, right side glide, and left side glide, and other clinicians won't even look at side glides. But if you can start to understand what activities make you worse or what activities make you better, then you can parse the activity into the position of the joint. And it might not be the joint where the pain is. It might be something higher, for example. As an example, if a patient to me says, my low back pain, my central low back pain is worse with walking uphill, better with walking on flat ground, worse with sitting in my car, better with sitting in my office chair, well then yes, we have activities of walking uphill and sitting in a car seat being worsening. But if we look at what that activity is in terms of the joints of the low back, well then the patient is actually telling me without telling me in these specific words, I get worse when my low back is flexed with uphill walking. I get worse when my low back is flexed in a car seat. So that's what I'm listening for. I'm listening for other things that are kind of unspoken, to be clear, but I'm really listening for, is there a positional report about joints, either movements or sustained postures that seem to be influencing this patient's presentation? And if there are those things in the person's history, then it increases the likelihood that the problem is actually mechanical or positional in nature. And if we can find out what's the offending positions, then we can usually find the improving position or movement. Is it always the opposite, as in I get worse with flexion, so I need the opposite movement with extension? No, it's not always one-to-one. There's a strong prevalence of that. There's a strong pattern for that we find in the office, but it's not always exactly the opposite movement that is fixing the patient's problem. But for people who notice certain things make me worse, certain things make me better, then I'm starting to listen for what positions or movements are those joints going through when these symptoms are increased or decreased, because that could be a really important piece of figuring out the diagnosis. And if the diagnosis is a mechanical joint derangement, well then by definition, we can fix it by moving it into the movement that it needs. One of those movements is just possibly one movement, sometimes two, but moving repeatedly into those positions and then temporarily reducing the exacerbating positions.